Hello and welcome to another Polestar Pilates Hour. It's good to be back in the United States. I had a 2-week trip to Korea. Shelley was with me, and Shelley continued on to Australia and New Zealand for another 2 weeks, just getting over a little bit of jet lag. Today, we are going to be looking at a frozen shoulder. So our agenda today is basically to go through a little bit of review of what is a frozen shoulder, what's the science of it, and then we're going to do a case, and we're going to be interactive today. Frozen shoulder is just an incredibly complex and frustrating pathology, and I say that wholeheartedly because so many times I have had patients with, we refer to it as capsulitis, but to deal with this frozen shoulder syndrome, I don't know if any of you, maybe you do a little shout out, let me know if any of you have had clients or maybe yourself suffered from a frozen shoulder. And what does that mean exactly? Adhesive capsulitis. And it's really a unique pathology in the sense that it doesn't respond like a normal orthopedic injury or neurological injury. So it's really a sort of a targeted population that tends to suffer from it. And what I'd like to do is just cover these 5 basic areas. We're going to talk a little bit about a definition. I've been doing a little bit of research this week, so I'm bringing you some of the current research on shoulder capsulitis. We'll look at the etiology, things that we think cause the frozen shoulder. We're going to look at some signs and symptoms, some risk factors, what predisposes people to the frozen shoulder, and then talk a little bit about a prognosis. Once we go through that little review session, then we're going to jump right into a case study. So adhesive capsulitis, also known as frozen shoulder, is an inflammatory condition characterized by shoulder stiffness, pain, and significant loss of passive range of motion. The long-term disability are reported at 10 to 20% in patients. So most patients get better is what that means, like 80% get full recovery. Adhesive capsulitis has a prevalence of approximately 2 to 5% of the general population, and the mean age is typically around 55 years old, a range from like 30 to 60 years old. And there's a slight predominance of female versus male. And the exact pathophysiology of adhesive capsulitis really is unknown, but there are some categories of it. So adhesive capsulitis can be classified as either primary or secondary. Now, the primary one is the one that we really struggle to understand, but it's a disease typically that has an insidious onset. What that means is that there was no accident, there was no trauma necessarily that caused it to come on. And it's often associated with other types of systemic diseases like diabetes mellitus or thyroid disease, or certain types of drugs or pharmacology that we take, or cervical spondylosis. There are certain events that happen or infirmities that are directly correlated or have a high correlation with shoulder capsulitis. The second disease typically follows trauma or injury to the shoulder, sometimes after surgery, fractures, rotator cuff tears, or being immobilized for long periods of time. And there is some more recent research that shows a possibility of a correlation with a gene expression. That there's what that means is that in our genetic code, there are certain expressions in that genetic code or telomeres that could be related to the disease itself. And we see this a lot with autoimmune diseases and endocrine problems. That's why we see things with diabetes and thyroid correlating to it, of this inflammatory process that causes the tissue disruption inside the capsule of the shoulder. So when we look at the signs and symptoms, we can break it down. This is why it has the terminology of frozen shoulder, is that there's the freezing stage, and this is when the shoulder becomes stiff and is painful to move, right? That's the first sign of it. Now, there's a lot of reasons why we could have stiff and painful shoulders: a rotator cuff, a bursa impingement, a little bit of arthritis, a tear of the labrum. There's lots of things that can cause that, right? But the pain slowly increases in this one, where typically in an injury, the pain gets better and better. And it may worsen at night, to the idea that a lot of people with frozen shoulder syndrome have very difficult time sleeping because of the pain. And I can just tell you, being one who's had a shoulder surgery, that was my first surgery at 16 from American football injury, that life sucks. Like, you cannot get comfortable sleeping, and it usually takes somewhere around 6 weeks before you can even get in a comfortable position to sleep at night. And this stage of the freezing is usually somewhere between 6 weeks to 9 months. And this is one of the things I want to make very clear, is that we're not going to cure the frozen shoulder. We have to work around it. We have to try to restore function, but we're not going to cure it. It takes us time. We do not know of anything that really makes a difference. I'm going to present some things that are anecdotal that I found that help me as a Pilates teacher and a physical therapist to work with patients that have it today, but understand that we do not have an answer for it. And if you're thinking of 9 months for the onset, the freezing part where you lose the range of motion and you have pain with it, that's a very long time to suffer with shoulder pain. Stage 2, or the frozen stage, is where the pain may lessen a little bit, but the shoulder remains stiff. So you'll see them, they can't get their shoulder up. They have pain at the end of the range. It's more difficult to do their daily activities, and this stage can last for 2 to 6 months. And then the final one is the thawing stage. And again, we don't really have an effect or know how to do this, but we see that just in the time frame of these 3 stages that these happen. In the thawing stage, the pain lessens and the ability to move the shoulder slowly improves, and they get close to full recovery. And that could take anywhere from 6 months to 2 years. So the take-home message here is that a frozen shoulder or adhesive capsulitis usually going to be a 1 to 2 year process that we're not going to speed up. One of the things that happens often is if a physical therapist or orthopedic surgeon get too aggressive, all we do is make it worse, right? We inflame it more, we limit the range of motion more, we make it more painful, they lose more function. And what we really need to be thinking of is, like, how do we work around it to be able to increase function, increase mobility, and decrease pain. So that's going to be some of our objectives today. So risk factors, this is what we see associated or correlated with this, is that it's most commonly between 40 to 60-year-olds. I mentioned women more than men. It can be related to recent shoulder injuries, as I mentioned, a lot of times due to bracing or shoulder surgery or shoulder dislocation. Any of those things can lead to potential capsulitis. I had a patient that had fractured her humerus in a car accident, right? So right in the neck of the humerus, and she had to have surgery to fixate it with a little plate and some screws, and was put in a sling for a while. And that healed up nicely. We got it actually moving quite well, not a big problem. But about 6 months later, guess what? Adhesive capsulitis set in, and she then went through that 1 to 2 year period where she had significant shoulder pain and dysfunction. I mentioned diabetes. So between 10 and 20% of individuals with diabetes develop frozen shoulder. So we are in an epidemic of metabolic disorders, probably due to the amount of sitting that we do as a society these days, that our metabolic disorders have skyrocketed. Now, this particular problem is not particular to diabetes mellitus 2 or diabetes mellitus 1. One is an autoimmune disease, often hitting children, where their pancreas and the goblet cells don't produce insulin, so they're insulin deficient. So there has to be some kind of relationship between how the insulin production in the body and the inflammatory process that leads to a frozen shoulder. It's also not uncommon for people that are dealing with a more systemic problem like diabetes to have one shoulder be a problem, it gets better, and then the other shoulder becomes a problem, and they end up getting both shoulders affected by the frozen shoulder. Other health conditions and diseases, stroke is one that's fairly high. And again, you think of stroke, I'm not sure if it's more just because they have the weak and shoulder muscles on that one side and they have impingement that it leads to irritation, inflammation, or if there is some type of chemical or hormonal imbalance that happens there. Hypothyroidism, or an inactive thyroid gland, or overactive thyroid gland, Parkinson's disease, and heart disease also seem to have a relationship to frozen shoulder. Now that, again, could be chemically or inflammatorily induced types of problems that we would see in the shoulder. I do see that Christine threw up a question here just asking about menopause. And again, if you think of the age bracket and the gender specific, you're looking at 40 to 60 and you're looking at female. So like I said, I think that it's probably due to some kind of hormonal changes, inflammatory changes that are happening in the body. We certainly could make a relationship to perimenopause, menopause, and postmenopause kind of things in that 40 to 60-year-old female. The prognosis I mentioned, and that's what's the likelihood of it getting better, right? What's the outcome? And typically, there's a spontaneous recover within 1 to 3 years. So physicians sometimes go in, they try to treat it by doing manipulations under anesthesia, surgeries, physical therapists try to mobilize. The common doctor is going to use anti-inflammatories. None of these things seem to significantly speed up the process of this 1 to 3 year frozen shoulder. And it's very frustrating if you're thinking of it as a rotator cuff problem that you would expect to see a change in a number of weeks, and now you're not seeing change for a year. So this is why this is such a particularly frustrating problem if you don't understand it. So treatment protocols, as I mentioned, pharmaceutical, the COX inhibitors, this is the anti-inflammatory, non-steroidal, and this is where you're looking at things like naproxen and ibuprofen and things like Voltaren and I'm trying to think of the formal name of Voltaren. It's slipping my mind right now. Still a little bit of jet lag from Korea. But the idea is that these particular drugs are COX inhibitors. So they are inhibiting the inflammation process, and the inflammation process is responsible for bringing in additional fibrin and causing a healing process that thickens the capsule and makes it so that every time you move the capsule, it gets irritated, more inflamed, more thickening, more irritation in those first 2 phases of the frozen shoulder. Therapeutically, as physical therapists, chiropractors, occupational therapists, we tend to look at restorative mobility, particularly to the scapula and thoracic. And I want to repeat that. So as Pilates teachers, if we're dealing with somebody that is suffering from adhesive capsulitis in the shoulder, we could be thinking a little bit more of like, how do we get more movement in the lumbar, thoracic spine, the rib cage? How do we use breathing? How do we get scapulothoracic rhythms and movement, even if we don't have very good movement in the glenohumeral joint for a year? And if we can distribute movement, that's one of Polestar's basic principles, distribution of movement equals distribution of force, we can take away some of that irritation that's causing the pain in the shoulder. A couple other things there. We look at strength training within the available range of motion without pain or without increasing pain. This is where the Pilates equipment is fantastic, right? The tower bar and the trapeze table is probably one of the best tools we have for frozen capsule problems in the shoulder. So we can work in this very small range of motion with assistance without irritating, but start adding strength and some sort of awareness training in the shoulder of the range that they do have. We're not moving into the end of range of motion, but we're trying to strengthen them within the range of motion that they have. We got a couple questions that have come in. It's a good time for me to take them. Maggie Reeves says, is there any correlation between frozen shoulder and scoliosis? Now, I haven't seen a correlation or read of a correlation between spine anomalies and frozen shoulder. But remember, position could also do the same thing. So think if you had a thoracic rotation or lateral flexion scoliosis, it would put the glenohumeral joint at a disadvantage on that side. And so there might be greater irritation. Now, once you have irritation, if they happen to have the other comorbidities like diabetes or other problems, then it might be a higher likelihood that they do have a relationship between that scoliosis and a frozen shoulder. I particularly have not seen it. I haven't read about it in the literature. I was just looking at a meta-analysis yesterday that looked at all the studies and really it has not been one of those things that's listed on there. Sarah Edwards said, if mobility does not speed up recovery, are we to then focus on stability in the area, or am I jumping ahead? Give me a little bit of time and we'll talk about that. You're not jumping ahead. This is the idea. This is the challenge we have with frozen shoulder, right? This is, it's like we talk about tissue adaptation. We've talked about it a number of times here on the Pilates Hour, that if we don't do enough load, we don't cause adaptation of the tissue. If we do too much load, we cause tissue damage or inflammation. Well, this becomes particularly sensitive in adhesive capsulitis. So we want to try to have a little more function and strength in the arm in a pain-free range. That's the key, right? Or a minimal discomfort range that's not irritating the tissue, so that we can increase function, at least of things like being able to eat, get dressed, brush your teeth, things like here, because they're not going to get the arm back up overhead or over shoulder for quite a while, even with our best therapy interventions. Lorna Jarrett said, myotonic dystrophy, DM2, tends to have shoulder dysfunction. Could the systematic connection be the culprit with the disease as well? I'd have to do my research on that, Lorna. I'm going to take the fifth on that one today so we can get focused on it, but I promise I'm going to look that up. That's a great question, if there's a muscular dystrophy relationship with shoulder girdle. Again, anytime we're looking at something that has an inflammatory response, hormonal response, we're probably going to see some kind of relationship with this type of pathology. And then I have Lori Winslow that asks, are those with hypermobility, right? We talked about this not a couple weeks ago with Marcia, who was talking about Ehlers-Danlos and hypermobility syndromes, and at more or less risk of developing frozen shoulder. And I don't know the answer to that. I think that because it is a connective tissue disorder, I haven't necessarily seen that they have more restriction in movement, but certainly the pain and the loss of stability and control in those extreme ranges of motion. And I'll have to, again, do some research. These are great questions you guys are presenting. So here we have our client that we're going to talk about today. Sharon is a 45-year-old female with a diagnosis of adhesive capsulitis on the right shoulder. She's right-handed, so you know what that means. And she's in phase 3 and manifests with pain and limited range of motion, impairing her daily activities, things like being able to comb her hair, brush her teeth, get dressed, put a t-shirt on, fasten a bra. Those are all things, even going to the bathroom, being able to wipe, showering, all of those things can be a challenge when you're dealing with frozen shoulder. And at this stage of the game, remember, she's just starting to thaw. So this is a good time for us to be able to do some Pilates with her. So let's give you a little more insight, right? When in her interview, I always ask, what do you believe you're able to do that you believe that you're not able to do that you believe you should be able to do? And her still biggest problem by far is sleeping through the night without pain. And then she's unable to perform overhead activities, including dressing and hair, as I mentioned. And when you ask her, what do you believe prevents you from participating in these activities? It's a pretty straightforward answer. It's pain and lack of range of motion. And these are the two main complaints of a frozen shoulder. And again, it gets frustrating for us because we don't have a quick solution to it. Even with injections and passive manipulations do not seem to speed up the process of the healing. Then all of a sudden one day they start moving better and feeling better. And it's not because of us or without us. It just, it's like, how do we improve the quality of their life here? Let's see, I can tell you from personal experience that scoliosis, and particularly the kyphoscoliosis that I had, can wreak havoc on every joint in the body. As a teacher in training, my goal is to learn how to help myself and others with this problem. I'm certain that my rib cage rotation affected, etc., caused the inflammation in my shoulder. I also have snapping scapula. And I think that's something we're going to talk about, Catherine, in the sense of our problem solving is how do we help people when we know that the pathology itself might have to take its course? But if we have the belief of whole body movement and whole body wellness as you're going through your training, how can we increase, for example, if I'm in kyphosis, no matter what, I'm not going to get that range of motion, right? But if I can increase extension, all of a sudden that same range of motion in my hand opens up and gives me enough range of motion to comb my hair in that same range of motion. So if they were in kyphosis or scoliosis and closed down on that side, it's going to have a very an increased impact on their daily activities. Before we go on to that first question, actually, let's go to the first question. Before assessment based on subjective information up to this point, what would you hypothesize Sharon needs the most right now, right? So this is just you thinking like, here she is, she's in a phase 3, she's starting to unthaw, she can't sleep very well, she's not using her arm to do any kind of overhead activities. What do you think she needs the most right now? Go ahead and put in your answers, and I'm going to answer a question from Fiona James while you're doing that. So Fiona said, have you had success with frozen shoulder that has been frozen for an extended number of years? My mom has had frozen shoulder for probably 30 years from lifting patients in her nursing career. She is looking at surgery now, and I'd love to find her a Pilates instructor in Scotland who can work with her. Fiona, we can certainly help you with finding some Pilates instructors. The key here is that if it goes longer than 1 or 2 years, it really does become surgical, and they can do things like manipulation under anesthesia, or they can release the capsule. And at 30 years, it's for sure going to be a true capsular restriction that would have to be opened up and released, and then she would need to have some good physical therapy and rehabilitation after that. I'm looking at the answers that are coming in here as we scroll through, and looking at small ranges of motion. I love it. Movement rehab. And again, the movement's going to stay inside that pain-free range of motion. We're not going to necessarily try to increase range of motion at this stage. We're going to allow the range of motion to increase. And there's a little bit of a difference in those two statements. Did any of you hear that? One is us forcing her to increase her range of motion versus us allowing at the stage 3 or phase 3 for the thawing of the frozen shoulder to take place and having less and less restriction, and then working within that new range of motion. How do we educate and restore control and stability within the new range of motion every day that she's going to be getting over the next couple months? I saw one, restoration of arthrokinematics. I love that because I love the idea of what's happening inside the joint. So even in a safe space, or what we call unpacked joint position, right? So it's sort of about in this range of motion here. This is the loose packed position for the joint. So just doing some movement in here with maybe some assistance or springs from above that she's pulling down could significantly improve the rotatory component or the arthrokinematics of the shoulder joint. Pain control is going to be important, keeping her out of painful range of motion, because every time she goes into pain, she causes a little bit more inflammation, more limited movement. It's a catch-22. Very good answers. From the medical diagnostic test, right? So in reality, looking at things like MRIs without differential and without doing some contrast testing, it's very hard to be able to see what's going on in that capsule, right? If you do a contrast, they can often see that there's a thickening. They can see that there is an active inflammation process, or that it's starting to get better and the inflammation's a little bit less. But she was clearly diagnosed by her doctor with a stage or phase 3 adhesive capsulitis. Active range of motion when the doctor sent her was flexion to 80 degrees, abduction. So 80 degrees is about right here, coming forward. Abduction 70 is a little bit less, about right here. And then external rotation, she couldn't get up past 45 degrees. And then as far as internal rotation, she was 0. She couldn't go past the neutral position. Pain was still a 6 out of 10. And then power within that range was a 3 out of 5, or 3+ out of 5. So she could lift her arm a little bit against gravity, but could not get anywhere close to that 70, 80 degrees on her own. Okay. In her limitations, and this is how I want to communicate with Pilates teachers that I work with, is to be able to think of the principles of movement and how they pertain to this particular case. So physical limitation, she was upper extremity mobility limitation. And she also had upper extremity power or control limitation. So we're already identifying that she needs mobility, she needs power, and then the sleep limitation secondary to pain was a physical limitation. the big picture, if we look at our ICF model or the International Classification of Function model or grid, we look at this functional part, right, of what she wants to participate in. And the activities that she's limited in is overhead activity, arm over activities, and dressing and hair care. These were the three main things that she felt were just really difficult for her, including sleeping. So with this information, treatment that I was doing with her as a physical therapist, what I was prescribing was neuromuscular reeducation, right? So we're going to work within the range that she has to start educating a more functional response within that range. Strengthening within the range of motion with modified loads. That's what we do in Pilates. That's what's beautiful. That tower bar becomes just an amazing tool for shoulder pathologies like this. The doctors were doing injections with steroids every 3 to 6 months, trying to decrease the inflammation of the capsule itself. The outcome, slow improvement. Plan, I wanted to refer her to Pilates on a long-term. Acute physical therapy didn't have a place for her anymore. She had already been dealing with this for a number of months, 7-8 months, and now she's in that phase 3 of thawing and just wanted to have a really good experience in Pilates, a whole body movement. So getting her there and then educating the Pilates teacher to make sure that they're using the concept of assistive mobility treatment to that shoulder. Very, very important. What functional tests would you want to do with Sharon, right? So the functional tests we talk about in Polestar, the screening test or the Polestar assessment tool. If you're not familiar with those, you can think of any kind of movement assessment test. Go ahead and give us your best shot of what kind of test would we want to know as a Pilates teacher of where they are at this stage, so we can compare before and after treatment of if they're getting better or not. While we're doing that, we have a question from Steven. It says, with tensegrity in mind, are there adjacent non-shoulder muscles or joints that can be worked on that will help free up the shoulder? Now, Steven's reading my mind because we know distribution of movement equals distribution of force. So if I can't get access to the glenohumeral joint, can we get access to the scapulothoracic and to the costovertebral joints? And if we can restore extension and rotation in the spine, the upper spine, and we can facilitate glide of the scapulas, then that's going to greatly improve the access that they would have with overhead activities. I'm seeing some good tests coming up. Keep it coming. The next question I have is from Catherine Connor. Hello, Catherine. Thanks for joining. I see your name all the time and appreciate your support. Comment, another condition related to frozen shoulder is post-mastectomy surgery in breast cancer patients. Absolutely. As a 34-year-old breast cancer survivor and breast health educator and Pilates and exercise instructor, I've worked with many patients, students, helping them to regain their range of motion with their pain tolerance level with positive results. And the difference here is, status post-mastectomy and lymphatic issues in the upper extremity have a whole nother set. Same idea. We're going to work within creating these successful movement experiences without pain. So if we go back to sort of Polestar's vision of, hey, let's create these successful movement experiences without pain. How do we do that? We modify load, we modify range of motion, we build tolerance, gradually increase that tolerance until we restore function. So this is where we also affect the belief model of how people see and feel themselves. And sure enough, I saw a couple of them up there. You're doing great. So goalpost, she was unable to lift the right arm past 80 degrees. So again, she's here. And it was also reproduced her pain. So right away, we know this is a great test because we know if we're doing better, she's going to be able to get her arm up a little bit higher and higher and eventually be able to lift the arm up overhead. So we get a good baseline measurement of where she's at, right? Pre-swan, right? So here we are with hands down on the ground trying to see if she has thoracic extension, right? Minimal to no upper thoracic extension. So this goes back to Stephen's question. If I can restore thoracic extension, right, it's going to be directly related as far as increasing mobility of that shoulder girdle. And it's not going to relieve the stress and pressure of the glenohumeral joint. This is where we can make great strides in the Pilates using things like spine corrector or the new spine fitter. If you haven't purchased a spine fitter, I would suggest that you get one. They're inexpensive. You can order from Balanced Body. In Europe, you can get it from Sissel. But that spine fitter is a great way of getting some of that thoracic mobility and the costovertebral mobility that we observe here in the pre-swan test. Superman or Superwoman, I saw some of you list that as well. She couldn't lay prone, right? So we put her in supine, a modification, if you've seen that test, and she was able to elevate her arm to 90 degrees and pain at the end of the range of motion laying on her back. So again, great landmark. We know that without lifting against gravity, just holding it straight out in front of her, that she could get to 90 degrees with pain at the end of range. And so our goal is, can she get it up a little bit higher in that laying supine position to where she could actually get her hand behind her head and start taking care of her hair and those things that she wants to return to. Side lift, she was unable to get into a side lift position on the right side. So that's something that we tried to do that test and she was not able to get in that position. And that would make sense, right? So if we look at that, we might have to put her on things like a spine corrector, laying on her side and letting the arm dangle down a little bit so she could start getting some load through it, but without pain and without too much load. So here's the next question. What do you believe could help Sharon regain her ability to perform her ADLs with the right upper extremity? Let's get some responses in there. What do you think could help Sharon regain that? We sort of talked a little bit about it. Now we've seen what we hypothesized and we saw what test and the test results that you suggested. Let's see what you say about what we should be focusing on with Sharon to gain a little more function in that right upper extremity. I see from Sarah says, successfully navigated a mastectomy for cancer last year. Pilates kept me sane. I think we're going to have a Polestar Pilates hour on breast cancer. So if any of you experts out there in breast cancer, I'd love to have you as my guest. Send in email to me or to Melissa. Let us know if you're interested in doing that. We can have a little chat offline. But I do think we need to start talking a little bit about cancer treatments and post-cancer and cancer survival on this show as it pertains to movement. All right, so we're seeing some things come up with some responses. And again, take your best shot. The beauty of this is it's anonymous. So you can take a shot in the dark and see if you come up with a good idea as you compare yourself to ideas from others from all around the world in the Pilates industry. So I see breathing exercises. Thank you so much, whoever said breathing exercises. I'm thinking that the OOV is a fantastic way of, we talked a little bit about the spine fitter, but the OOV in particular, it's just amazing at restoring thoracic mobility and getting a sort of a myofascial release as well. I see improved thoracic mobility and scapular rhythms, if that is the focus, and tower bar, lateral loaded OOV. Those are all some great ideas that create a modification to the load and create good access to movement through there. Breathing, lying on the roller, fantastic ideas. These are all great ways of looking at, and you give me exercise already, but the idea is like, what modalities can we use to be able to really help her out, right? So we see focus on mobility. We look at props that are going to be able to help restore that thoracic mobility. I think that's the big thing, right? Graded load through the upper extremity in a range that she can tolerate, and then increasing the thoracic and scapular thoracic mobility to be able to take some of the pressure off of the impingement that accompanies that frozen shoulder. And when I see swimming there, I'm thinking, are we talking about water exercises, or are you talking about the actual Pilates swimming exercise? If we're talking about water, I think we're right on the money. Water is a fantastic aqua therapy. She can get in the water and the water will be buoyant and allow her to get her arms up floating without having to use too much of the rotator cuff load or the deltoid load. Very good. All right, so here's some insight, movement strategies, right? So based on your information, a lot of you said exactly the right thing. Sharon's lack of thoracic extension and poor scapular mobility contribute to the limitation of right shoulder flexion and function. So we want to use that antagonistic approach. Now, here's me about 40 years ago or 30 years ago, I don't know. using the antagonistic approach to shoulder mobility. You can add 15 to 20 degrees to shoulder flexion and abduction almost immediately. So the beauty of this is a lot of times this is true with shoulder impingement. This is true with coming back from a mastectomy surgery, that where you're not able to lift the arm up against gravity, but we can bring the handle down into the hand with a bar sprung from above. So what we've created is an assistance, but the idea is that the muscles that control that bar now are the antagonistic muscles of elevation. So it's going to be the latissimus, the serratus, maybe a little bit of lats that are going to be controlling that, right? So the spring pulls the arm up. They don't realize it. We're telling them, I want you to just work on pulling it down. So when you're dealing with shoulder impingement, frozen shoulder, weak shoulder, shoulder reconstruction, total replacement of the joint or reverse replacement of the joint, these are fantastic exercises. Whether you have them in supine or sitting, the springs from above focus on the antagonistic muscles. So what does that do for the agonist muscles? It inhibits them. So the rotator cuff, the deltoids are told to relax when the spring is being pulled up because they're using the antagonistic muscles to control that. So this environment is very powerful. It could be also having a TheraBand around the cage of the trapeze table and having just hold on to the TheraBands and pulling down with the TheraBands, letting the TheraBands pull them back up, right? The tighter the TheraBands, the more they're going to get assistance going up. And that's what we're looking for, is creating that assistive environment. This is also the place that we can work on some arthrokinematics. We can focus on the arthrokinematics of the joint. So as the elbow's being pulled up, we can give them the visual that the head of the humerus is dropping down. And that's going to create space. And because they don't have to hold their arm up with their deltoids, they're not going to have that moment arm that's pinching the rotator cuff or the capsule or the bursa, and that space is compromised right now. So this is a beautiful way of doing that. Now, also movement strategy, looking in supine of things just like doing protraction, retraction, or being in kneeling and putting the hands on the bar and letting the bar go out a little bit, or closed chain activities on the reformer. So these are all some ideas I want you thinking about that have to do with closed chain, open chain, assisted movement strategies. So how can we help Sharon regain her thoracic mobility and re-educate her shoulder girdle mechanics to provide function without pain? So now we've talked about it. We've thrown out some ideas. Time to see if you're listening and thinking and continuing this train of thought of how we're going to help Sharon. So let's get some answers up there, see what you come up with. Lori Winslow, thank you. She said, I've attached light springs to the slide bar along the top while they are lying supine. Same concept. And once you understand this concept, thank you for bringing that up, Lori. Once we understand this concept, we can use pulley systems, elastic bands, cables, gravity eliminating devices like TRX. We can use things to be able to provide these successful movement experiences for our clients while they're in these painful states. So we can get very creative once we understand the concepts of it. I always joke around in the physical therapy world that once we understand the concepts of Pilates and the philosophy of Pilates, we can become much more effective in any environment of conditioning and training, whether it's water or resistance training or band training. All of those things, if we understand the concept of graded load and assisted range of motion and gravity elimination and basis support, we can really make great strides with our patients. Let's see what you guys are saying here. So could we do seated on the box reformer pulling straps? Absolutely, is down low. So as long as it's a light load, doing something down low, that could be. Progress in pain-free range of motion, slow is tolerated. Mermaid on the reformer, that's a good idea. Closed chain, they might not go out very far, so they might have that right hand on the reformer and push out a little bit, but they might only get to push out to that 50, 60 degrees, but we're creating load within a safe range of motion. And as they get more control, remember that closed chain is going to stimulate the mechanoreceptors and increase the proprioception of the joint. So anytime that we can do closed chain in the upper extremity in a safe range of motion is a great way of increasing the awareness of those joints. And we can also shift it from going like glenohumeral joint to actually going into scapulothoracic joints or protraction or rotation around the thoracic spine without ever having to lift up into an impingement site. If child's pose comfortable helps to breathe, expanding ribs. Now, one of the things with child's pose, right, is they might be able to get in sort of a modified quadruped position, right? And I would suggest even like the tower, the foot bar is a nice way of doing that in quadruped. And the arms are actually coming down to about 45 degrees. And then as you push the carriage out, the arm goes up closer to 90 degrees and back down. That's, again, a safe range of motion, closed chain, high proprioception. Prone scapular series, that's one of my favorite, very early on. And I do this because, remember, you can scoot the body back towards the head far enough that the arms are actually down lower in sort of like a 60-degree range of motion that we start doing scapular series. It doesn't have to be directly underneath it at 90 if they can't get to 90. Let's see, down shrugs, hugs, standing off the Cadillac, pedipole, great. Again, all spring assisted, Swiss ball against the wall. One of the things that I always tell people is when we're dealing with this sort of antagonistic training, right? So we start with the tower bar pulling down. Then we tell them, hey, it looks like it's getting a little heavy for you. Let's lighten the springs. Well, lightening the springs puts more load on the elevation muscles of the shoulder, right? It's a good little trick. And then we say, hey, you're getting a little tired. Let's go let go of the bar, and let's get a little sticky Gertie ball or gym ball or Swiss ball, and let's roll it up against the wall up and down. And by using the triceps to push the ball into the wall actually creates the assistance, and they're often able to get a higher range of motion with that because of how you're creating these positive movement experiences. All right, so as we've talked about here, what principles of movement would you prioritize with Sharon, right? And none of them are wrong. It's just a matter of sort of seeing what we collectively, as right now we're 134 people on live, what we collectively think would be your priority. Where do you want to spend the most time or energy of this particular client of ours? Right. I see a couple of things that had come in. Lanvi said that work on her spine mobility first before work on her shoulder mobility. Big fan with the fascia work. Yeah. And, I always have my 10 integrity model, right? So we're thinking of how do we, with this idea of frozen shoulder doesn't fit into our biotensegrity model, right? It doesn't make sense. So if we think of the biotensegrity model, how do we try to balance out the elasticity, the tension, and the compression around that glenohumeral joint? And I think that's part of our whole body movement approach. How do we create that whole body movement? So as I'm looking at your post here, we're 25 in. Mobility is in number 1, breath is number 2, and movement integration number 3. I love it. I'm not too worried. Alignment is where we talk about things like the arthrokinematics, or we talk a little bit about congruence. So it is very important as well to get congruence of that joint so that we're not always pinching up into the chromium, that we might be able to find safer ranges of motion to work. Control is going to be things like, how does the rotator cuff do its job to help maintain that space and prepare the arm to move? So again, each of these principles is very important in this situation. I do agree with sort of the weighted ones where I would use a lot of breath to facilitate thoracic mobility and some scapular mobility, movement integration, working with things like rotating the lower body, thinking of knees side to side. Those are all some great ways to get a little access underneath the shoulder. And that's sort of a nice little trick in our movement. So summary. With Sharon, we're going to focus on functional activities, right? We want her to be able to get dressed, put a shirt on, get her bra on, to groom hair, face, sleep without pain. And again, this is one of the ones that's most disturbing. If we don't get a good night's sleep, then we tend to be in a more inflamed state. I don't know if you've ever noticed that, but if you go a couple days with very poor sleep, we often feel just thick and inflamed, and it's the body's reaction to a lack of repair time and healing time. So we might think of ways that we can use props and pillows or different ways to get her to where she can at least get 4 or 5 hours of comfortable sleep at night. All right. Structural limitations: thoracic restrictions in all plane, myofascial restrictions in chest and shoulder girdle. So you guys sort of hit that one on the head. Very good ideas of how we can get that sort of tensegrity again across the chest, across the scapula, intercostal, how we can use breath to be able to get a little more myofascial release. We could also refer to some manual therapy if we needed to get some thoracic manipulation or some myofascial release across the chest and the back. And then the last one, which I think is super important, is strategic limitations, right? So she has poor shoulder girdle and thoracic mechanics. And a lot of that, if you just think of having pain, what we do is we hold it, like we protect it. It's just too painful to move. If you've ever had anybody with regional pain syndrome, this is where there's a hypersensitivity in the sympathetic nerve system. I think I presented this once upon a time here on the Pilates Hour. But it's the same thing. Like it just starts ramping up the sympathetic system of protecting, inflammation, vasoconstriction, the areas that we don't want it, vasodilation, the areas we do. So it's like just having this whole systemic response. So how do we create a positive movement experience without pain that can facilitate, successful, even like a little trick of, how to get the head in a position to be able to do what you're going to do with hair. I don't have that problem, of course. But with your hair, without having to think of the old way of just lifting the hands up over the head, it might be that we can bring the head down to the hands, or teaching some strategies that can really help, knowing that this is going to be a problem for another 6 months, right? We're not going to just break through this problem, at least not traditionally. I think this is our last question for you, interactive. And this is where we get to just throw down a whole bunch of exercises. You've put some things down already. But if you were to have Sharon, what would be the top 2 or 3 exercises that you think would be part of your whole body workout to be able to help restore that thoracic mobility, restore that scapular thoracic rhythm, restore the strategy and function, these positive movement experiences for Sharon as part of her Pilates program? Now, a couple of you have mentioned being breast cancer survivors and that Pilates sort of saved you and your sanity. And a lot of times it's moving the rest of the body. So I want you also thinking of, how do we have whole body movement? How do we incorporate our key principle of breath into these things to be able to provide these little mini successful movement experiences for Sharon while she is rehabilitating and recovering from adhesive capsulitis? While you're answering that question, I'm going to answer a few more questions. We're coming into the last few minutes of our program today. Maggie Reeves said, how would this assessment be different if she was still in stage 1 of a frozen shoulder? That's a great question. I don't know that it would be that much different, Maggie, but we would have an expectation, for better or for worse, that she's probably going to get worse before she gets better in stage 1. So the key is thinking of, like, how can we provide biomechanical strategy for her to minimize the painful experiences that cause a decrease in range of motion in stage 1. So remember, stage 1, they start having pain, then stiffness, and then they get into the adhesive in stage 2. So if we can somehow maintain a lot of that passive active range of motion with assistance without pain, and we are masters at that, right? If we can get to somebody of early onset, we can maintain a lot of that range of motion functionally before they get to the real frozen stage in stage 2. And that could mean that their freezing now is somewhere up here, which allows them high function. They just can't get up to here, right? So that's a great question. Appreciate that, Maggie. Christine said, Brent, did you have fun assembling your tensegrity model? I assembled it, and then I disassembled it, and then I tried to assemble it again, and I did a horrible job, and I had to go back into the book and try to figure out and make sure that it worked for me. So yes, it could be a little, if you like puzzles, that's a great model for the puzzle. Thank you for asking, Christine. Jody said, comment, I found Dr. Kirsch's shoulder pain book regarding hanging like a primitive, very helpful in increasing my acromial arch when healing a snow shoveling injury this spring. And then last thing here, Jody said a primate monkey, was just clarifying that. You know, one of the things that it has continued to show good success is just doing Codman circles, right? So Codman circles is just where you sort of bend over and you move the arm around in circles to keep some mobility in there and preventing some of the stiffening and the restriction there. All right, so breathing on trapeze table. Thank you for bringing breath into it. It's such an important part. Antagonist approach, split pedal on the chair, fantastic. Seated extension work, working within the range that they have, pulling straps. And remember, we're in stage 3, so she's going to be getting more and more range of motion naturally over the next 6 months. And we need to be strengthening and increasing function within those 6 months and within that range of motion. So these are good exercises. Book openings, basic bridging, arm arcs, great. Pedipole, all exercises. Pediple's fantastic. I was just with Curious Sabin in Korea, and you know, the Fletcher family is just amazing with the pedipole. They're really taking it to heart and have so much to offer to us. Forward and reverse punches, incorporating trunk rotation. Again, even thinking if you kept the arms in close and could facilitate that rotation and scapular gliding, fantastic. Thoracic mobility on the spine fitter, swan on chair seated, great ideas. Rolling like a ball. Again, any mobility of the spine is going to improve mobility of the shoulder girdle, right? Because it's distribution of movement equals distribution of force. You guys are doing great. This is good stuff. Long back stretch with rollback bar, swan with rollback bar. Right, arm marks with the bar on the small barrel. So that bar to me is one of the most powerful tools. You know, and we just have to see what they can handle. I love that somebody put Tai Chi up there. Tai Chi was my primary exercise for rehabilitating my hip, actually, getting up into standing activities, doing some Tai Chi movements. Take-home lesson is that as far as we know today, that doesn't mean it's not going to change if we start understanding how to deal with, for example, the genetic identity or sensitivity, the diabetic or systemic kind of pathologies. But the reality for us today, in most cases of frozen shoulder, is that you're looking at a 1 to 2 year time frame. Early onset, the more that we can maintain the mobility before they go into the frozen state, the more function they'll have during the whole course. When they're in the frozen state, it's very hard to make change. That can last up to a year in some cases, so it's a very challenging time. And as they go into the thawing stage, we want to keep training without pain or without increasing pain in those available ranges of motion as they come back and return. We take advantage of our Pilates environment that manipulates load. We take advantage of the concept of whole body movement. We know that if we restore mobility in the spine, the shoulder blade, that can carry over to increase function. Distribution of movement equals distribution of force, and allow us to participate fully in our daily activities, hopefully by the end of that whole sequence of that frozen shoulder. I think that's about it for today on this lesson, and we'll be back next week. We're going to have Claire Sparrow, one of our senior educators in the UK, and we're going to be talking about women's health, so I'm excited about that. The following week is another friend of mine, Tracy Litt, who we're going to be talking about really gaining more of the emotional, psychological alignment. We talk a lot about physical alignment. Tracy Litt is an expert on this, so she's a good friend of mine, and we're going to be able to talk about that. Just a couple announcements of some things coming up. We have a transition intensive with Shelley, August 18th to 20th and 25th to 27th in California. So anybody on the West Coast that's with us or that sees us and wants to have an amazing experience with Shelley, that's coming up. I have 2 critical reasoning courses coming up that are in person. One's going to be in Oakland, California, and the other at our flagship site in October. And that's going to be fun for us. So those are some really intense courses that we get to have live clients come in, and we practice those skills of assessment and designing programs for them. Also, just to let you know, a shout out that the book Principles of Movement has been opened up for pre-sales. So if you go to Amazon.com and you look for Principles of Movement, you will find the new book, and it should be available for shipping somewhere in September, October, but they are doing pre-sales now. So if you're interested in that, go ahead and make that order. We also have a number of publishers in foreign countries that have expressed interest now in being able to print that book as well. So if you know of somebody in your country that is a publisher or translator in different languages, we'd love to hear from you. We'd love to get this book into as many hands as possible in their native tongue and language. So thank you, everybody, and it's good to be back with you. We've got 2 exciting weeks coming up. Please tell your friends, invite your colleagues, let them know that this is a great time for us to learn and to share with each other. Above all things, as we always say, be kind, and I'll see you next Thursday at the Pilates Hour.